stronger. It's my pleasure to introduce Dr. Fortin, I believe. He's a psychiatrist at the Royal, and he and I partnered together about 4 years ago to change the telemedicine a little bit, add Northern Francophone programs. We also expanded into some areas of Ireland that is French-speaking. So we've done a lot of great stuff together. We have 15 regional clinics, and now we are working to partner with academic institutions like yourselves, as well as family health teams, CHCs, and community agencies, shall I say? Dr. Fortin.
Good. Hi. Good afternoon. Thanks everyone for making the time to join us. I'm Benjamin, Dr. Fortin, a psychiatrist with the Royal. I'll be standing here using the microphone because we're video casted. So I just want to make sure I'm recorded. So sorry, I'll be standing still a little bit. Just for my sake, I think we have 60 minutes roughly today. Yes. Okay. Thank you. I'm getting nods. And just to get a sense of who's here, can people shout or just let us know? I see people from residence, there's people from health services, counseling services. I'm not 100% familiar with all the services you have for the students here, but if you could just give me a bit of an idea. I'm very impressed by your facility. This is my first time at Algonquin College. Everyone was very proud in the cafeteria to tell us that your food services win awards. So yeah, obviously I'm French Canadian, so I didn't do my schooling here, but it was very, very nice to partner with you and very nice to visit you in person. Most of the services to the students that will be getting services through the clinics will be done via televideo. So this is what we do with other regional partners. So the idea is that people get access to specialist care, that's me, so psychiatry, without having to go to a mental health hospital like the Royal, and people go where they usually get their counseling, their primary care, and then our input gets embedded into your record. So the idea is to empower and build capacity locally for students or for other patients in Ontario accessing healthcare. So who's around? Who's in the room today? And from health services, nursing, social work, GPs, who's?
Yeah, I think we have nurses today. Manager.
Okay. All right. And counseling services as well, I heard. Yes. Okay. How many people are counselors or? Okay. Awesome. And how many people are from nursing? No? Okay. Okay, good. So this side of the room is very much counselors, and the other side, you guys are more. No? Yeah. What type of profession, what type of background do you have on the right side of the room? Because everyone raised their hands for counselors on the left side. I'm just curious.
Counselors, mostly disability counselors,
Okay.
health services, residents, keep going with everybody. What else? We have support, people who work with students with disabilities on this side.
Okay, good, perfect. So it's a, yeah?
Yeah, and we're here from the student engagement and experience area as well.
Okay, any students in the room? Hi, welcome, thanks. Okay, good. So this is a little bit of a medical talk, but don't hesitate to ask questions, and I think it'll give you a bit of an opportunity to see also maybe the language of how we tend to frame things, but it's also fairly therapy heavy, because so what I do at the Royal, I work in a veterans clinic, that's the OSI, the Operational Stress Injury Clinic. Also do electroconvulsive therapy, so that's shock treatment. So I get the feeling that I'm still a real doctor, I don't just talk to people. But most of my time is in the telemedicine program. So part of it is supporting CHEs in Champlain. So that's Cornwall, Hawkesbury, Petawawa, but also in Northeastland, Thimmins, Hearst, Kapuskasing. Okay, so let's just get started. I'm going to talk about anxiety disorders, how common they are, what are key features of the main diagnoses that are part of that category. We'll talk about some theoretical models to formulate anxiety disorders, and we'll review a couple of cases. Just to give you an idea, so anxiety disorder as a group is the most common form of mental disorders as listed in the DSM. We're talking about a prevalence of about 30%. Now, a lot of that is accounted by specific phobia, so fear of spider, which is not typically a very specific phobias don't tend to be overly debilitating, but anxiety disorders become quite prevalent. I'll talk about what those are, but just to give you a little bit of an idea. So most anxiety disorders tend to be more common in women, with the exception of obsessive compulsive disorder, which is a bit more of a 1-to-1 ratio, and more younger men as opposed to, well, more boys as opposed to young girls in childhood, and that's because of Tourette's syndrome, where men are more at risk for the combination of ADD, so attention deficit disorder, OCD, and tics, and Tourette's. So you can see that true obsessive compulsive disorder is the least common of anxiety disorder, right? So if in your practice you have 10% of patients with OCD, you probably want to reconsider those diagnoses. Is this really accurate? Because that should be rare. Social anxiety disorder is the most common of anxiety disorder, and then PTSD, GAD are more around the 6 to 9% prevalence. Panic disorder is a little bit rarer, and we'll talk about what those are. So just people come with anxiety. Anxiety is a symptom, right? So people say often, I suffer from anxiety, but it's a little bit like I'm suffering from sadness, right? So anxiety is not a pleasant state to be in, but it's not an illness per se, it's a symptom. And we want to link it to a disorder because that's going to influence treatment. Anxiety disorders, so generalized anxiety disorder usually has the latest age at diagnosis. Separation anxiety disorder, specific phobia are more common in childhood. Social phobia happens more around the teenage years. And so you see just the median age of diagnosis for each of the disorders. So again, anxiety is a symptom. People come, present as anxious. We want to figure out a little bit what's the anxiety about. Is it connected to an anxiety disorder or not? And that gives us an idea of what we might be looking for depending on the age of the person presenting with that complaint. And thinking about anxiety disorder, we want to remember that anxiety is a normal phenomenon. It's just a normal anxiety. It's part of everyday life. Like stress is normal. Stress is not a bad thing, right? When we want to treat anxiety, whether it's with psychotherapy or meds, we tell people we don't want to remove all your anxiety or your stress. I still want you to feel a little bit anxious before you cross the street, because I want you to look to the right and look to the left so you don't get hit. And so there's normative fears that most people will have. So this is a child psychiatry slide, but we're looking at, very normal for a 2-year-old to be somewhat afraid of strangers. Very normal for a 3 or 4-year-old to be afraid of the thunder, afraid of imaginary creatures. So there's normal fear, and then when people reach adolescence, then it's normal to be afraid of being rejected by peers. But when it crosses a certain threshold and creates impairment, becomes debilitating, then we're starting to talk about an anxiety disorder, right? So the corresponding anxiety disorder to those normative fear. So just useful to think about that, right? So it's normal to have fear of rejection, but if it becomes disabling, people can't leave their home, can't talk to anyone, then that might become social anxiety disorder. The DSM-5 shifted a couple of things from DSM-4. So all those 5 disorders that you see listed used to all be in the same chapter of anxiety disorders. Now they've created 2 separate chapters, one for obsessive compulsive and related disorder. So OCD now is connected to body dysmorphic disorder and hoarding. and then post-traumatic stress disorder and related disorder is also a separate chapter. So those are all disorders that will have anxiety as part of a main feature. So fear and worry is a key part of all those disorders. But then we found that in terms of neurobiology, there's really something specific about OCD that's different. And so that's why they put them in their own chapter. And then for PTSD, what's unique about PTSD in the DSM is that all those disorders, the trauma and stress-related disorders, are connected to a life event or a series of life events. So the common denominator in that chapter is that something happened in people's life that made them sick. So just for that chapter. I'm still lumping them here for convenience, and because they've always been introduced together, and the Canadian guidelines on managing anxiety disorders are the guidelines that we use for OCD and PTSD. So they're still, I think, connected. And from a clinician's perspective, people come and say, I worry all the time and anxious. They don't necessarily tell you I've got one disorder in that particular chapter. So I think it's useful to connect them. I'm going to get you to do a little bit of the talking here. So each of those anxiety disorders tend to have a specific fear that organizes the symptom. So what would be the specific fear that organizes the stress and dysfunction in panic disorder? What are people with panic disorder afraid of? Dying. Dying would be part of it. Dying from what, like in panic disorder? What might be fatal or
Like sudden death.
mm-hmm. As a consequence of, yeah, Aliette?
Feeling trapped.
Yeah, so that's definitely part of it.
So fear of fear itself, the feeling of fear is the phobia.
So the fear of being trapped, the fear of dying usually results from a panic attack, right? So someone has an anxiety attack where their heart is racing, feeling very dizzy, might get sweaty, the room is spinning around them, and they're afraid that this panic attack isn't just their fight or flight system acting out. They're afraid that they're having a heart attack. They're afraid that they're dying. They're afraid that they'll never be able to escape, or the attack's never going to end. And so the fear becomes organized around the panic attacks, right? So panic attacks happened in many different disorders. Actually, most of the time, panic attacks happen in people who don't have an anxiety disorder. But when the fear of having another attack and the fear of the consequences of the attack starts to organize people's life, where what they can or can't do because of the risk of having an attack, that becomes panic disorder. In social anxiety disorder, what would be an organizing fear? What would be the kind of the core fear belief that preoccupies people with social anxiety disorder? Yeah.
Rejection.
Yes. So rejection, and rejection coming from negative evaluation. Like, people will think I'm funny, people won't like me, people will see something that I don't like about myself, they'll see it, they'll know right away. And as a result, I start avoiding situations. I can't eat in public, I can't speak, I can't do my oral presentation. I'll need to hide, or I need to take 3 shots of tequila before I leave my home to go to the party. Otherwise, my anxiety gets in the way of me just sounding normal. Yeah. And generalized anxiety disorder is that total fear of loss of control, catastrophe, something bad's going to happen, and I'm going to be helpless in front of it. So it's just a bit more generalized or kind of vague, like something's going to happen. I don't know why, but it's going to happen. In PTSD, what would be the central fear for post-traumatic stress disorder? You guys are doing great. Just keep going. Yeah. Yes, and it's exactly that. So something bad has happened, and now I can't live my life normally because it could happen again, right? So the idea isn't, so something bad has happened, which is very unfortunate, but it's already happened, right? But what's getting in the way of people living their present life is that fear that it could happen again. And the goal of treatment of PTSD is we're going to try to help people feel safe again. And I'm doing, I think we have, how many talks do we have in this series? I think we have 6 or 8. 8. So there's 8 talk in this series, and I'm doing 2 other, one on insomnia and one on post-traumatic stress disorder. So I won't talk too much about PTSD today, but the treatment of PTSD really is we're trying to help people start feeling safe again, right? So the trauma has already happened, but they're still stuck there, stuck in that fear. We're going to try to help them work through what happened so that the fear doesn't get in the way anymore. And OCD is a little bit trickier. I think I did see someone with OCD as part of our Algonquin clinic, formerly through Upstream. So has anyone worked with someone with just good, true obsessive compulsive disorder before? Yes. What would be a theme? What would be a big fear, big concern? Like, if I don't comply with my ritual, if I don't flick the light, 10 times until it's just right, what could happen? What seems to be the fear there? If I don't wash my hands well enough, what's the fear?
This student's case, the fear was that if they didn't do all this, the rest of the day would not go well. Like, you have to basically prepare this particular repetition so that they can carry on with their day. If that ritual didn't go well, they couldn't take the next step to move on with their day.
And often somewhere along those lines, there's also a fear that if I don't do it, something bad's gonna happen. And if I don't prevent that bad thing from happening, indirectly I'm responsible for what happened. So it's the fear of causing harm or failing to prevent harm is often part of those beliefs that tends to organize the obsessions and compulsions that are part of OCD. So we talk about a case, and I'm very excited because this is not an Algonquin case, but I did my first half-day clinic for Algonquin last week, and I saw a young man who was presenting with the exact same story. So it's very relevant. So this is a case of Jillian. Jillian's 37. She's complaining. So she comes to, so in health services, do you have a kind of a walk-in or crisis, or does counseling have walk-in or crisis? Yes, both? Good, you guys are so available and so responsive. It's amazing. And residents, you probably have walk-in also. Good. So perfect, this applies to everyone then. So Jillian comes to a walk-in clinic. And complaining of racing thoughts and insomnia. She's like, my mind just won't shut up. I can't stop thinking, and it's keeping me awake. She's feeling very overwhelmed. Something got a little bit worse after her daughter became pregnant, and her daughter's addicted to cocaine, and so she's very worried about the health of the grandkid-to-be. She's very agitated. She's talking about a minute. It's really hard to interrupt her to ask, well, what happened? Why are you so stressed? And so we start wondering, could this be part of bipolar disorder? She's so accelerated that this is an hypomanic episode where she doesn't sleep, talks about a minute, she's got lots of ideas, feeling agitated inside. Is this mania? Is this hypomania? We're not sure. So we're wondering if this is hypomania. And so the person that saw them at the walk-in clinic at the time said this is probably hypomania. We'll just give you an antipsychotic with mood-stabilizing properties. So olanzapine. Olanzapine's fairly sedative, acts quickly. It's going to make you sleep. It's really going to help with your mood. And it's a great crisis medication. Acts quickly. We don't want to keep people on it for so long because it's comes with a lot of weight gain, comes with some abnormal movements. But crisis works well. And then we see her in follow-up. And then in follow-up, we get a little bit more information. So she has no history of substance abuse, medical problem, medication. So it's not, hyperthyroidism or a new prednisone for asthma that's making her anxious and agitated. It's not drugs. Doesn't seem to fit with bipolar because it's not really an episodic pattern of illness. And it's not someone who's always overwhelmed or goes from crisis to crisis when we're talking about, say, personality disorders, because really our relationships have been fairly stable and there isn't that sense of instability. On the other hand, she does describe having always been very cautious. Like she's really good at figuring out what might go wrong in a plan. She's worry, takes a long time to make decisions, often double checks. She can usually function very well, but at times of higher stress, she'll get headaches, GI upset, insomnia because of her worry. So what do you think might be your diagnosis in terms of, so we rule out other major causes. We're pretty sure it's an anxiety disorder. What anxiety disorder do we think it is?
So I'm just curious, was
Yeah.
the initial diagnosis bipolar 2?
So at that time, we don't really know. So bipolar 2, bipolar 1. So if someone has a manic episode, so 4 out of the 7 criteria of mania, and lasting for at least a week, we're going to go bipolar 1. If someone has hypomania, so we're looking at 3 out of the 7 criteria, more for 3 to 4 day episode, then that would be hypomania. So we're not sure. So initially we saw her, so she's super agitated. Is this hypomania, mania? Is this part of bipolar? We'll give her something that will help and will work regardless of it's hypomania or mania. But then on follow-up, so when she comes back to the clinic 2-3 weeks later, it doesn't really fit a bipolar picture anymore. So we're revising our diagnosis, and this is where we think, okay, not a bipolar-related disorder, probably an anxiety disorder. And of those disorders, which one? What do we think? Probably GAD, generalized anxiety disorder, and we've got lots of head nodding, good agreement on GAD, yes. And this is, okay, so the funny thing, this is exactly what happened with the gentleman I saw last week. So it happened, so before I saw him, so I think he's actively in counseling, or was in counseling last academic year. So referred appropriately to his GP, to health services earlier this summer. And he's quite agitated, quite accelerated. It's hard to get him to focus in conversation. So there was a thought, is he hypomanic? And just referred to the clinic. And this had happened in 2017, when he was enrolled in another institution, sent to emergency psychiatric services, prescribed olanzapine, and then seen by a psychiatrist and follow up 3 weeks after. And he said, there was high stress. It looked like you were very agitated. Could have been bipolar disorder. It's probably GAD. So what defines GAD? So the criteria are, so we're looking at excessive anxiety or worry on more days than not for at least 6 months. So this is a longitudinal problem, not just acute. And the worries are related to more than one spheres of people's lives. So it's work, it's school, it's relationship, it's health, and so on. Hard to control the worry. And worries are going to come with a feeling of being restless, keyed up, on edge. Worries burn people out. So like worries consume a lot of energy. So people are fatigued. They have difficulty concentrating, right? So a lot of the time, the presenting complaint will be, it's hard for me to focus. Do you have a learning disability? Do I have attention deficit disorder? So we just explained that, worries are extremely distracting. Of course, it's hard to focus on your course load when you've got all those thoughts interrupting you all the time. And worries make people irritable, and that's especially in men sometimes. We see a little bit more of, snapping, losing patience, irritability, and so guys are just not great at saying, hey, I'm worried. They're impatient, everyone's getting on their nerve. So sometimes you just need to do a little bit of digging to figure out, maybe there is anxiety, maybe there is worry, there is fear underlying that irritability we're seeing. And of course, the somatic symptoms of anxiety, so muscle tension, headaches, GI, all sorts of things. Good. Common differential diagnosis. So when I'm talking about differential diagnosis, right, so what we do in mental health, is in any areas of healthcare, right? People come with a complaint, and we make up an hypothesis, and then we're going to test out that hypothesis. So differential diagnosis is always sort of what else could explain that complaint. So the ADD is a big one. I can't focus. I'm so distracted. I must have ADD. So good way to differentiate it is usually, ADHD is a neurodevelopmental disorder. So we're talking about a lag in maturation or deficit at the frontal lobe level. So, and our frontal lobes is what matures last in terms of brain development. So we're looking at an illness that is present in childhood. It usually gets better with time. Now in school, it's a little bit tricky because sometimes people have enough, can compensate a little bit for their deficit, and then as school gets harder. So when you go from high school to college, this is when all of a sudden it becomes a problem. So sometimes we do detect it later, but still in the story there should have been problem earlier. So it's a neurodevelopmental disorder. Whereas anxiety, as we said, GAD is diagnosed, it's got the latest age of diagnosis, around 33 years old. So not uncommon for GAD to be diagnosed when people have moved away from their parents' home or are asked to become a bit more autonomous in their learnings in the transition from high school to college. It would make sense to diagnose GAD more so than diagnosing ADD. We're usually at 20, 21, like this should be a little bit better. This is bipolar, so racing thoughts. Insomnia is part of mania, but usually in mania, people are grandiose, they're happy, things are great, they're gonna fix the world, we found the secret to the universe. So it's slightly different. The content of thought is different. And just one last thing essentially is that sometimes anxiety is just part of depression, right? So we talk about depression as sadness, but depression is altered mood. It can be more worry, it can be more irritability. In terms of treatment, psychotherapy is more effective than weightless or placebo, so psychotherapy works. CBT is definitely the most studied. It's not the only one that works, but very well studied. It works in one-to-one, in group setting, phone-based, computer-based, workbooks with support, all are effective. Less study, but there seem to be good result for other approaches, short-term psychodynamic, acceptance-based therapies, so ACT, acceptance and commitment therapy. Common theme, so we want to address people's intolerance to uncertainty, poor problem solving, and the metacognitive beliefs. It's the idea that if I don't worry, then the bad thing I'm afraid will happen. So the metacognitive belief is that worries are useful. As part of CBT, we provide psychoeducation. This is generalized anxiety disorder. It's somewhat common. This is what stress is, this is what normal anxiety is. This is why we think you've reached the threshold, it's probably a disorder, and we want to do something deliberate about it. Helping people monitor anxiety and their triggers so people can start making sense of what is anxiety, what are the thoughts that come with it, what's my emotional state, what are the physical sensations that come with anxiety, and then we want to challenge certain beliefs and rehearse coping strategy. In terms of medication, so you'll see the so antidepressants, so as SSRIs, so selective serotonin reuptake inhibitors, and serotonin and noradrenaline reuptake inhibitors, SSRI, SNRI, are all first-line treatment for generalized anxiety disorder, and there's an anticonvulsant there, pregabalin. So all first-line. So there's usually enough first-line agent that if someone's not tolerating one agent or not getting good response, we just cycle through first-line options. What I tell people usually, what in terms of what they can expect from medication is, and medication will take 2 to 8 weeks until it works. But usually what we're looking at is things will become a little less heavy. So you've finished a conversation with someone, you go home, you rethink about what you said and how silly it was or what might have gone wrong, and you do that for 20, 30 minutes, and it keeps you up and say, well, you're going to go home, you're going to think about the conversation, but if the medication is working, you'll do it for 5, 10 minutes, and then it's going to be easier to let it go. So the worries don't disappear, they don't go away, but it's a little less heavy, it's a little less painful, people are a little less dragged down by their anxiety, and it's easier to shift away from that sort of constant rumination. There's, yeah, some evidence for adjunctive therapy, but every time we combine or add medication, usually the effect size of treatment in terms of how much benefit we expect from what we're adding is much less than what we typically would expect from a first-line pharmacological agent or psychotherapy. Okay. So in terms of the effect size, so when we do studies, it seems that usually the effect size of psychotherapy seems to be a little bit larger. So sometimes people are just not doing very well. It's hard for them to engage in week-to-week treatment. And so medication certainly makes sense. If people don't want to take meds, it's okay because psychotherapy works very well too. So usually in the real world, we just tend to combine. But if meds only work partly as opposed to just trying to add on meds, I usually try to just really highlight the importance of psychotherapy. Monitoring treatment, it's useful to administer scales on a regular basis just to see how people are doing. And when anxiety happens, it usually feels like there's a crisis now. It's been a crisis. It's been a crisis for many weeks, and it's always going to be a crisis. So it's hard to look back and say, oh, actually 2 weeks ago I was doing better. So that's why I think those scales are useful, just to track things through time. So the GAD-7 is a commonly available scale. And that's probably something you guys use in counseling services. Do you use scale to monitor outcome sometimes, maybe?
PHM.
Okay, what's the PHM? Okay. Perfect. And that probably covers it. Like there's lots of different vendors, lots of different packages. The best scale is the one you know. so it actually means something. So that works perfectly well. Yeah.
These are both good ones and we use them. You can always find new scales, right?
So if you're interested, those are all public domain, all free and available. Any thoughts, any questions on GAD?
Are you seeing increases in the numbers of people with this? On the whole, are studies showing there's increases? I mean, we're seeing a lot more mental health coming through our doors. So in terms of numbers, even anecdotally speaking, we're seeing more of those students. But are you seeing enough in Royal at your level, or are they mostly seen by family physicians?
So as a couple of things in that question. So I think in terms of prevalence, I think for anxiety disorders, the numbers have been fairly consistent over time. So the bigger epidemiological studies in the States would have been in the 80s, as around DSM-3. And I don't think those numbers have changed very much. So that's a good thing. Our rates of detection are probably better. So hopefully more people get treatment, which is a good thing. And the other part is, do people get access to specialized care? And I think sometimes anxiety disorders haven't necessarily gotten the attention they deserve, right? Because people don't necessarily come to the emergency room or have the type of crisis that will require them to be treated as an inpatient. So sometimes, yeah, we haven't necessarily structured our services well enough for people to get good care through time, because they're quietly sick, not quite functional enough, and it's a bit of an illness of missed opportunities where people just don't live their life to the fullest, but they're not necessarily creating, there isn't the type of crisis that will get a hospital's attention, unfortunately, yeah. It's a good thing if we're seeing a little bit more of it. Yeah. Any other thoughts on GAD or anything? Yeah?
So we often have to characterize if a disability is permanent or not.
Okay.
Because in order for a student to reduce their course load, and if they're on OSAP, they need to have a permanent disability.
Yeah.
And so they have to send away documentation there, but sometimes we apply that criteria to all students to ensure that it's fair. So
Yep.
if we get a letter that says student has GAD,
Yep. So the course, I can actually. Let's do that now because I'm not sure we're going to get to it. No, you're not. Sorry, you're not seeing my screen. Let's jump here. Sorry, slide number 26. Sterile. Can't jump to. Welcome back. So the degree of disability and the course isn't just determined by diagnosis. So all anxiety disorder can have that type of trajectory, right? Where mild severity, about 41% of people diagnosed with an anxiety disorder will usually be fine, may need care in a more episodic fashion. And so those are people that will, we might say, like they're having an episode of disability related to GAD. Let's get their back on their meds, or let's try to find a medication that works for them and agrees with them. Let's see how they do with 12 weeks of therapy, and then we'll decide. Some people will have a severe course and have disability, and that can be GAD, can be social anxiety disorder, can be PTSD, and then some people will be somewhere in between. So it's part of it is related to diagnosis. So you're seeing, so this is complementary to the slide we just saw. So in terms of the trajectory, so you're seeing the mild severity, so the lower line, moderate, so the middle line, and the more severe chronic. And then we're looking at factors that seem to be associated with what course. And so GAD, so generalized anxiety disorder, has a higher proportion of people being in the chronic disability trajectory, as opposed to panic disorder, which has more frequently people with milder symptoms. So it's really hard, it's hard to tell from the get-go what trajectory people will be on, but if you see GAD, you suspect there is a bit of a higher risk of chronicity and long-term disability versus panic disorder. We should be pretty encouraged and say, let's try to be aggressive here. Like, let's try to see, now, again, if I'm OSAP or, like, I have filled that questionnaire once for someone, so I've seen it, so I have a bit of an idea, but I'm not entirely sure. Every time we're filling those, we're wondering what type of decision is going to be made on account of this. So I tend to tell people that what I'm telling their insurer is very different than what I clinically think. So I usually tell insurer, this is terrible, this is permanent, it's going to last forever. Like, make sure to alleviate as much stress as I can. But I don't want patients to take this as a clinical prognosis. Like, I don't want them to think that I'm suggesting that they're never going to be able to function. So it's just, yes, maybe I shouldn't say those things, but.
We know that, but when we just have
Yeah.
like, so because we're applying that criteria to
Yeah.
all students, OSAP or not,
Yeah.
when we get a letter that says just a diagnosis, is it reasonable to assume it's always permanent if there is a DSM diagnosis of a mental health disorder?
And I guess diagnosis is one factor,
Yeah.
but the same diagnosis can mean a very different level of disability. I have, colleagues in the hospital who have one of those diagnoses and are doing just fine, and may need to take a leave of absence for 6 to 8 months once every 5 years. And so it kind of depends on the purpose, I guess, of the questionnaire. But so diagnosis is one factor, and not the only one. Other factors that will influence the course, age of onset. So the longer someone has had their anxiety disorder, the more chronic, the more risk of dysfunction. And then I will send the slides, but you can look at, protective factors, being enrolled in school, in work, being partnered, the usual suspects. But diagnosis matters, but isn't necessarily the number one determining factor here. And we'll go back to case 2. But great question. Any other thoughts? Sorry, I think I've ruined suspense here. It's okay. All right. This is a 22-year-old, so a bit more in your age range. Although I was surprised, so just looking at the population, you have a lot of more mature students here, right? So you see people from all walks of life, which is very interesting.
I'd say most students are late teens to early 20s, but we are seeing more and more mature students in our student population.
Good. I'm like, that's one for me, more variety. Okay, so we're seeing Kevin in clinic. He's 22-year-old. He's what we would have usually called Asperger's, so a higher range of autism spectrum. So in autism spectrum disorder, what used to be the cutoff between severe autism and Asperger's was language, right? So Asperger's, typically you've got normal language, normal IQ, but the deficit is going to be around social emotional reciprocity. So his mother brings him in clinic because he's got wild temper tantrums at home. He insists that everyone removes all objects from countertops all the time. If they're not in use, he often walks around in home naked unless he's able to get a freshly clean towel. So if there isn't fresh laundry from the day of, he's going to be naked until he dries. And that's that fear of contamination being acted out. So what we'll see is people not walking on cracks, not... how does OCD manifest itself here? So you'll see students being very late because they're having to comply with their rituals at home. So that's type of anxiety. Sorry. So he comes to the office and he's walking a little bit funny. So he takes 2 steps and then takes 1 step back. And so we ask him, so what was that? What just happened? And say, oh, it's just a double step. And it's a little bit hard, but he's starting, but he's able to articulate that, if I don't comply with the double step, something bad's going to happen. And an example of something bad happening was that I'll probably run into Joe, who was my bully in high school. So he's still got that fear of, if I don't do the ritual, something bad's going to happen. So I kind of gave it away, but, and yes. Good. So it is obsessive compulsive disorder, and then one of the bigger differential diagnoses here is how much insight do people have into those beliefs, right? So how likely is it that if you don't do the double step, your mom might have cancer, right? Or how bad is it? And so we're trying to establish, is this psychotic? Like, are people's reality testing? Is the reality testing still intact or impaired? So it looked like delusion, and sometimes there is overlap, but most often it's somewhat different, or you'll see that this sort of quasi-delusional thinking is really just related to the obsessions and compulsions. He's got no other neurological condition. There's those obsessions, are very preoccupied with certain thoughts. Symmetry, cleanliness were big ones for him. And there's compulsion, so hand washing, counting, double step was part of it. And so he's got obsessive compulsive disorder. What makes for the presence of OCD is obsessions. Obsessions are thoughts. So they're thoughts, urges, images. So common themes, so cleanliness, contamination. Harder ones to elicit are sometimes there's a vision or an urge. I've got violent thoughts. I see myself harming someone. I see it's sometimes happens in the postpartum period. Like, woman would be very, very distressed. I keep having that thought that I'm gonna put my baby in the washing machine. Like I'm doing laundry and I can't. I get paralyzed. I get panicky because I'm afraid I might do something like that. So those are a little bit harder to elicit. So just nice to know about them so we can look for them. And people are bothered by the thoughts. They're trying to ignore, suppress, or neutralize them, and usually that comes with a compulsion. So compulsive behaviors are, compulsions are behaviors or mental acts. So counting, checking, talking back, like sometimes it's just in the mind and it counts as a compulsion. And the compulsion reduces the anxiety. So there's a real tension release phenomena in OCD, and that's the main characteristic there. And when we see it, it's just that tension release, which is a little bit different in GAD, where it's kind of more run-on rumination, or it's always the same fear, versus it's that there's a peak of tension with a little bit of a relief. You see that, so I think there was a young woman that we saw through the clinic, and recently, what did I see? I saw a 22-year-old who had been treated for tics, like he had Tourette's as a kid, but now is joining the workforce. This was challenging, and was coming back, and it really, and he was, his main presenting complaint was bursts of anger and irritability. He'd snap at people, but usually it would be because of that fear, because it had to do with an obsessions. But he presented with, I've got an anger problem, but it was kind of related to the Tourette and OCD that comes with it. Clinical distress, impairment, so the rituals and obsessions take up to 1 hour in the day of someone. So we all have some rituals, we all have some obsessions. It happens, like we walk in the airport and we're gonna have that thought to say, oh, make that person trip, or like we all have those thoughts. But we don't stay focused on them. We don't have, oh my God, I'm such a bad person because I've had that thought. Oh my God, what if I have that thought again? Does it mean I'm a bad person? And you start thinking about having that thought again, and all of a sudden you've got a fully developed OCD. Important to contrast obsessive compulsive disorder and obsessive compulsive personality disorder. There's sometimes overlap, up to 25%, but they're not the same thing, right? So OCPD, we're looking at, so personality disorders, it's patterns of how people relate to their emotions, their thought, to the world, to themselves. So the core criteria would be pervasive pattern of being preoccupied with orderliness, perfectionism, and control. People are preoccupied with details, lists, orders, schedules, to the extent that the major point of the activity is lost. Did you have fun? No, I was way too busy planning. Perfectionism interferes with task completion, so people procrastinate, they can't finish, they can't find the right word. Excessively devoted to work and productivity to the exclusion of leisure. Over-conscientiousness and inflexible in matters of morality, unable to discard worn-out items, reluctant to delegate, miserly spending style, rigidity, and stubbornness. So there's nothing there that has to do with an obsession or a compulsion, right? So as far as the DSM is concerned, OCD is very, very different than a little bit of anxiety and rigidity at the personality level, right? So most of the time when people say, I'm coming because I'm so OCD, they mean that they have a certain degree of anxiety, and it'll come across as rigidity, control, and that can be GAD, can be depression, it can be normal, but OCD is rare, more around 1.5% as we looked at the beginning. But when OCD is there, it's nice to have a little bit of a language, a little bit of a formulation, just to understand what this is about. So various different schools of psychology have formulated treatment plans, so they formulated the OCD differently. So one of the thought was that conditioned stimulus is paired with an unconditioned stimulus of danger, but then the association is maintained through escape. So this idea that maybe there has been an episode of illness at one point, but people make false association with it, and they never can work through that fear because they're so good at avoiding or so good with their compulsion. There's this misattribution of high probability of danger related to a safe situation. So there is a risk that I'm going to catch a common cold if I open the door using the doorknob. But people have the distorted belief that it's very, very, very likely. So it could happen, not that likely. And there's an exaggerated thought around the cost of the bad thing happening. So if I get a cold, I'm going to get pneumonia, I'm going to be admitted to the ICU, I'll probably die, or I'll flunk all my courses. So people have that beliefs that this minor thing is terrible, and that all or nothing belief also of, something's not safe, then it's dangerous. So just being aware, like someone coming with OCD may be thinking like that, this is how they conceive the world, so that can be useful. And then the other piece was what I was saying at the beginning, like the idea that if I don't prevent harm, indirectly I'm causing it. One of the model is therapy is exposure and response prevention therapy. So essentially, we'll want to help people understand that if they don't comply with their rituals, don't comply with their compulsions, it's probably still safe. Nothing bad's going to happen, right? So it is safe for me to touch the doorknob, but I might have to do it over and over and over and over again until I start believing it. And sometimes we will do imaginal exposure to expose people to their worst case scenario fear, so that they can start differentiating, I'm afraid that this could happen. Me having that thought, me thinking about that in fantasy doesn't mean I'm wishing it to happen, and me thinking about it doesn't increase the odds of this happening again, right? And so those principles apply to most anxiety disorder, right? So just defusing what's a thought, what's a fact, what's just fantasy or imagination versus what really happens, how much control do we have around others, our environment, if we think about thought reading and social anxiety disorder. So all those principles here apply, are kind of related. So it's nice to have an understanding of those schools of therapy, because then there's redundancy, there's themes, and then we're going to feel a little bit more equipped, a little bit more empowered. And just knowing about that, even though we're not delivering the full protocol ourselves, can just help in those short 15-minute conversations. Say, okay, I understand your fear. Let me help you. This is a fear. It probably won't happen. We'll do it together, but you'll see over time you'll be okay on your own. Medication, again, we're looking at SSRIs and SNRIs. So OCD seems to respond very well to a high dose of serotonin agents, so often higher doses than when using GAD or major depressive disorder. If the first-line agent is not effective, we choose another one, and then there's probably evidence to go to the second-line agent. Clomipramine is an old antidepressant, works very well, second line because of side effects. And I think I'm going to stop here because it's very close to 2. And also just a nice scale for OCD is the Y box, the Yale-Brown Obsessive Compulsive Scale. And you can see that therapy is a much larger effect size. So in OCD, it's probably one of the illness where we don't want to be too creative when it comes to med. We just want to find an agent that's going to work well for the basic, and then we want to emphasize therapy. And that's true of most anxiety disorders, but very, very true in OCD. And Yalbra. Okay. So there's more, but I think we're going to leave it at that for today. Sorry. Thoughts, questions in the last 5 minutes? Thank you. Yeah.
I did have a question that, post-secondary education is marked by a series of transitions.
Yes.
Transitioning, if you're living in residence, it may be the first time you're really going home.
Yeah.
You're taking a collection of courses, each one's a different professor and different requirements.
Yeah.
In college system, oftentimes pretty quickly you're moving into a work placement.
Yep.
And leaving the college, and then, within a couple of years, you're graduated and you're moving into the workplace.
Yeah.
I'm wondering
So it's a great time in life to get sick if you're predisposed to it. Sorry.
certainly it's going to be more stressful.
Yeah.
There is really no
Yeah.
time to take time out.
Yeah.
If you're going to stay on track with your peers. But I guess one of my main questions is, from your perspective,
Yeah.
is there anything that we can do as a college that would help, particularly for individuals that
think your first point is, like, I think noting and marking the transition is very important. There's a whole formulation of major depression, as related to stressful life events, often transitions in roles, right? So the student population is having all those transitions in their real life. They're also the transition in the life cycle. And so it is going to be risk periods for major depression. And so model of therapy I like and I teach is called interpersonal psychotherapy. It's a little bit of a plug, but it talks about transitions. But so knowing that part of the anxiety is normal and linking it to this is what's happening in your life that's making you anxious is a big part of it. Like sometimes, a lot of what we do, whether it's we think something is part of mental illness or just part of normal experience, is helping people organize what's been happening, helping people organize their distress, and starts with what happened in your life, how did it make you feel, and how did you behave as a result. So in anxiety disorder, the behavior are often going to be avoidance, and that reinforces the fear, and then it becomes a problem on its own. Depression, we're going to look at behaviors more around, say, withdrawal or isolating. So acknowledging the transition, giving people the language, helping people connect the dot, because right, how often do you tell students, say, hey, there's been a lot happening in your life in the past year. You've moved out of your parents' home, you're starting a new program, and you're doing your placement. And they look at you like, oh, it's true. Like, there has been a lot happening. So, and then I think that puts us professionals, is we want to make sure we don't over-pathologize too. Like, I mean, by the time students get to see me, they've usually been in counseling for a few months. They've seen GP a few times. So that protects me from giving diagnosis to people who shouldn't get one. But yeah, I think we need to keep that in mind, that yes, it is a difficult period. And then this is why it's important to have all of us involved around the students, because we know it's an at-risk period, but if we're there for them now, then we can still help them get their degree and create opportunities for their future. Am I kind of answering your question? Or yeah, okay, thanks. Any other thoughts, questions about, it can be about our clinics with Royal, it can be about students, but feel free to come and chat. We're not in a rush at the end, so if whatever's on your mind. I do hope, so when we're going to see students, we're going to send reports. Health services should get them usually within a function of about 10 business days. I expect that those are going to be shared with GPs, but also with anyone else who's involved around the students. And I usually also expect that the students will want to take interest themselves. So just use us. It's a great partnership. We're very excited. So thanks for attending today.
Thank you, Dr. Fortin, and this is just a small token. Ben would have done this, but he's had to go off to other things, so just on his behalf, I just want to say thank you. Thank you on our behalf as well. This is just very, very informative, and the depth that you bring is interesting. Thank you, everybody, for coming. Thank you. I realize you've probably got schedules, but if you have a moment to ask further questions, as Dr. Fortin has said, he's available. But again, thank you all for coming.
Thank you so much. Thank you. Hi, how's it going?
Good.
Good.
My name is Rose. I work in the health services. I'm a public health practitioner.
Okay.
So my question is, are you usually experiencing depression? So anxiety leads to depression, or is there no relationship between those?
There certainly is a relationship.
Leads to which?
I think someone with a an anxiety disorder is at risk of becoming depressed. And oftentimes, they don't consult until they get depressed. Because that's when it hurts. And when it hurts too much, then people start asking for help. So it's that funny thing.
Yeah.
At the same time, so it's just more around the story, like just from their history. Like, does it sound like they were doing okay, and something happened, then they got this abnormal mood, and anxiety is probably part of depression. Does it make that much of a difference? Like, I think it's useful for us to know. And then, because one thing is because if someone has an anxiety disorder we think triggered an episode of depression, we want to make sure that we treat the anxiety disorder. Like, we just want to make sure that we pay attention to it.
And you're treating the anxiety disorder and the depression at the same
Yeah.
time, or we're just looking at the primary symptoms?
Thank you. Very nice to meet you. Thanks for making all of it. So if it's just because the protocols are slightly different, like the because with say if you got say CBT for depression, this is not quite the same as CBT for GAD, for example. So we just want to make sure that we address that theme of tolerating, not knowing, recognizing and understanding anxiety versus in depression it's more about scheduling things that are going to be pleasurable and fun. You making sure you're connecting with people that are important for you. So we just want to make sure we hit those targets. Yeah.
Okay, that sounds good.
But at the same time, like if someone has depression and part of depression makes them anxious and have panic attacks, there's no point in treating a panic disorder. Like you can bring them on the elevator and say like as if you were treating agoraphobia. It's not going to fix their depression. That's why that nuance is useful. Sometimes it's more around the therapy approaches.
Okay, that's great. Thank you so much.
Thank you.
Really informative. Thank you.
Thank you for making it. Good.